بشكرك جدا صديقي العزيز. Thank you very much for your attendance. Thank you very much, Professor Inas Shaltut, for inviting me. Thank you for the conference board for inviting me. And in the following 14 minutes, we're trying to answer few questions about prediabetes. Well, here is the story of Yasser. Yasser is not one of my patients. He is a friend of mine. Yasser is 48 years, smoker, having positive family history of type 2, hypertensive, dyslipidemic, BMI is 31, he is obese, and he is physically inactive. One day, Yasser called me that he checked his blood glucose, and his fasting blood glucose is 114, the postprandial is 165 with A1C with 5.9. And he's asking, is he diabetic with this range or not? Well, what I've said to Yasser that he is in this range. He is in this gray zone between the threshold of normal glycemia and the threshold of the diagnosis of type 2 diabetes. You are pre-diabetic, Yasser. And here the questions started from the side of Yasser. Yasser asked me 4 difficult questions. The first question is what, the second is why, the third is how, and the last is who. Let me start by the first question of Yasser, which is why. Yasser is asking, why have I got this condition of prediabetes? Well, Yasser is actually having all the risk factors that can lead to prediabetes, namely obesity. We all know that abdominal obesity with such a high level of free fatty acids and the adipokines leads to insulin resistance. Yasser is dyslipidemic. And emerging data that the position of triglycerides in the liver and muscle can lead to insulin resistance. Not only that, but the position in the pancreas can lead to beta cell dysfunction as well. Yasser is hypertensive, and the hypertension is no more an association with prediabetes, but can be an etiological factor, likely due to overactivity of renin-angiotensin system. RAS overactivity lead to insulin resistance and might be involved in beta cell dysfunction as well. Yasser is having a family history of diabetes, and having a family history of type 2 diabetes increases the risk of prediabetes at least by 70%. Genes here are due to insulin resistance and beta cell dysfunction as well. Physical inactivity is an independent risk factor of prediabetes. Lastly, but not at least, smoking. Smoking is a risk factor of prediabetes due to the inflammatory state associated with smoking, which leads to insulin resistance. So this is the first question of Yasser. Why have I got prediabetes? Well, you have all the risk factors that can lead to prediabetes. So I'm not surprised to find you having a pre-diabetic range today. The second question is what? What are the consequences or complications of this condition? This is an important question, given that prediabetes is a very common condition, and here is the data. In the year 17, in our region, the MENA region, about 35 million, the diagnosed pre-diabetics, expected to double by the year 45. So it's a very relevant question. What are the consequences or complications that can occur with pre-diabetes? We all know that the natural history for pre-diabetics, that they will develop type 2 diabetes by time. So we all from many years that pre-diabetes will progress to type 2 diabetes, and everyone here is aware that type 2 diabetes is associated with both microvascular complications, neuropathy, chronic kidney disease, retinopathy, and macrovascular disease, coronary peripheral arterial disease, and stroke. Yet, there is a cumulative evidence over the recent years that prediabetes without evolving to type 2 diabetes is associated with vascular complications. Yes, prediabetes per se can lead to vascular diabetic complications, both microvascular complications, for example here, up to 25% of individuals with prediabetes do have an evidence of peripheral neuropathy. Formerly, we used to say idiopathic neuropathy. A big part of this idiopathic neuropathy ended up to be due to prediabetes. Not only somatic neuropathy, but autonomic neuropathy as well. Many patients with unexplained resting tachycardia or erectile dysfunction, prediabetes can explain that. The other microvascular disease, retinopathy, and look at that. The US Diabetes Prevention Program, approximately 8% of prediabetics had an evidence of retinopathy. This is consistent with data from Germany. Around 80% again of prediabetics do have an evidence of retinopathy. Lastly, in the microvascular disease, diabetic kidney disease, the pathology of diabetic nephropathy starts during the pre-diabetic state. And the prediabetes per se is an independent risk factor for the development of albuminuria. So prediabetes could be associated with microvascular disease. What about macrovascular disease? It's not actually much better. The evidence is clear that prediabetes increases the risk of cardiovascular disease by around 20% as per this meta-analysis. And data from Paris prospective study that prediabetes was associated with double the risk of cardiovascular mortality. So prediabetes is not that an innocent condition. It is not that, well, keep healthy, keep your weight less, not to get type 2 diabetes. No, prediabetes is a condition that can lead to vascular complications. And here is the second question is, what could be the consequences of prediabetes? The third question of Yasser, how to treat, what can I do, how to manage prediabetes? Well, the mainstay here is lifestyle intervention. Lifestyle intervention actually is very effective, and we have a solid evidence to support that. The US Diabetes Prevention Program, just by very simple methodology, losing 7% of weight or more, half an hour of brisk walking per day, and decreasing saturated fat could reduce the progression to type 2 diabetes by 58%. This was consistent with data from DACking study in China and diabetes prevention study from Finland. Lifestyle intervention works to prevent the development of type 2 diabetes. What about drugs? Any use for pharmacotherapy in this regards in Yasser in people with prediabetes? Metformin in this regards should come first. Metformin is recommended by several guidelines for the prevention of type 2 diabetes. In the US Diabetes Prevention Program, metformin could reduce the incidence of diabetes by 31%. So metformin is approved for that. Any other drugs? Well, quickly I'll pass by some trials. Data on pioglitazone. Pioglitazone could reduce the development of type 2 diabetes around 70%. However, this can be associated with side effects, as you know, of increasing weight and edema. Acarbose. It's not only decreasing absorption of glucose, but modifying the gut microbiota. And in the Stop NIDM study, acarbose use was associated with 25% decreasing risk of development of type 2. However, again, the GIT tolerance of acarbose can lead to discontinuation. GLP-1 receptor agonists have done very well in this regard, with figure reaching more than 80% in terms of decreasing the incidence of diabetes in pre-diabetics. And here you can see the term of regression to euglycemia. Lastly, but not at least, SGLT2 inhibitors, gliflozins. In pooled analysis of patients recruited in DAPA-CKD and DAPA heart failure have shown 33% reduction of incidence of new cases of type 2 diabetes in people receiving gliflozins in this study. So we have several pharmacological agents together with lifestyle to answer the question of how to treat, what should be done. ADA this year, to summarize, proved and confirmed that first line should be intensive lifestyle therapy, aiming at reduction of weight at least 7% with brisk walking half an hour per day. Metformin should be considered if the A1C is 6 or more, for this with BMI exceeding 35 and with ladies with history of gestational diabetes, not to forget to correct cardiovascular risk factors like hypertension and dyslipidemia. So this is this question of how we treat prediabetes. The last question is who? Or in other words, whom should be screened to detect prediabetes? Should we test for everyone? No. Again, back to the ADA for this year. We should screen everybody above the age of 35 for the detection of prediabetes. And we should screen everyone, regardless the age, who is having BMI of more than 25 and one or more of these risk factors. First degree relative with type 2, hypertension, dyslipidemia, physical inactivity, polycystic ovary, and features of insulin resistance like acanthosis nigricans. These are the criteria to answer the question of whom should be screened for prediabetes. Mr. Chairman, dear colleagues, to conclude, prediabetes is such a gray zone transition between normal glucose tolerance and type 2 diabetes. Yet, we have effective intervention that we can do in this stage. Prediabetes is not an innocent condition. This can be associated with both microvascular and macrovascular complications. So, interventions need to be started as early as possible. And bottom line, that lifestyle intervention remains the main player here. Thank you very much for attention.